Dr. Hak Jean-François in France, who will present the topic endovascular management of vasospasm after aneurysm rupture. So please, Dr. Hak Jean-François.
So, dear all, so many thanks to allow me to talk about endovascular management of vasospasm after subarachnoid hemorrhage. So, my name is Jean-François Hack. I am a senior physician in the neurology department in Marseille, in France. So, I have no conflict of interest to declare. So, what do we know about cerebral vasospasm? It is known that aneurysmal subarachnoid hemorrhage, SAH, accounts for less than 5% of all strokes. But patients' outcomes remains poor, with the mortality rates up to 45% and a significant morbidity among survivors. It is mostly explained by the cerebral vasospasm, which leads to unfavorable outcome in 34% of the cases. So some definitions which will be used all along this communication: the severe refractory CVS, cerebral vasospasm, and the delayed cerebral infarction. So about the CVS, it corresponds to, it happens despite the best medical treatment, and it corresponds to clinical data, digital subtraction and geography data, and ultrasound data. About clinical data, it corresponds to a persistent or worsening deficits. For the DSA data, it corresponds to a worsening of the narrowing. And for ultrasound data, it corresponds to abnormal transcranial Doppler velocities. About the DCM, the delayed cerebral infarction, it is visualized on the brain CT or MRI within 6 weeks after SAH and not present on the admission CT, performed 24 or 48 hours from the admission, and not due to other cause as a iatrogenic complication, as with a surgical clipping or endovascular treatment. Historically, it was thought that DCN was only explained by CVS, but some studies noticed that CVS is not a necessary or sufficient condition for delayed cerebral infarction. Especially Nadesh and al. Found in their cohort that 62% of the delayed cerebral infarction were not explained by CVS. The rate of delayed cerebral infarction without severe vasospasm is variable in the literature. Thus, asymptomatic CVS can be found in until 99% of patients at D7 after subarachnoid hemorrhage. In the other hand, in their cohort, Verhoeven and al. Noticed that only 20% of their cohort of severe vasospasm led to delayed cerebral infarction. And we know that 24% of the delayed cerebral infarction occur without any CVS, without any cerebral vasospasm. Besides, it is admitted that treatments targeting the cerebral vasospasm are still disappointing when considering clinical outcome. So now we know that the pathogenesis of the delayed cerebral infarction is hypothesized to be multifactorial. And first with the cerebral vasospasm, but it is also explained by the microthrombosis and thromboinflammation, the neuroelectric disruption with especially the spreading depolarization, inflammation with the cellular mediators, sympathetic nervous system activation, the increased intracranial pressure, and the blood-brain barrier disruption. So what about the guidelines? The only level 1A intervention to treat cerebral vasospasm is oral nimodipine. About the endovascular management, including the mechanical angioplasty, the balloon angioplasty, and the chemical angioplasty with the intraarterial vasodilatator infusion therapy, it is only a level B for the American Heart Association guidelines and only a level 4 according to the University of Oxford Center. Recently, Grégoire Boulouis realized meta-analysis with 62 studies, including 9,000 patients, comparing endovascular management versus the best medical treatments, and data revealed that refractory cerebral vasospasm patients treated using endovascular interventions have lower relative risk ratio of unfavorable outcome with a relative risk ratio of 0.68. So what about the conventional angioplasty? It is called conventional because it is performed by most physicians. Proximal balloon angioplasty are performed for arteries with a diameter up to 2.5 millimeter and located proximal to the first angulation of the cerebral arteries, corresponding to the M1 and the A1 segments. About the intraarterial chemical angioplasty, it is performed with nimodipine alone or combined with milrinone, corresponding to chorotrop. In our center, intraarterial chemical angioplasty are performed with infusions for 30 minutes of 2 milligram of nimodipine, 4 milligram of chorotrop, also called milrinone in France, and 31 milliliter of serum glucose. Both have generally been shown to successfully treat vasospasm and improve neurological condition with no clear benefit from one treatment to another. To note, it is important to note that chemical angioplasty drawback is its short time effect and thus need to be repeated. So these two main approaches are used alone or combined during endovascular management. The CVS angioplasty is broadly used in acute SAH facing refractory vasospasm corresponding to a vasospasm refractory to a hypertensive treatment with vascular filling and respect of the normovolemia. The triple H management is no more recommended. So even if these two main approaches are broadly used, their efficacy were only proved with feasible studies and retrospective meta-analysis. In 2011, Sentian and al. Reported distal angioplasty for refractory CVS, performed for arteries with a diameter of more than 1.5 millimeter and located proximal to the second angulation of the cerebral arteries. So with their cohort of 80 distal target vessels, the authors reported good efficacy, few procedural complications, and a good outcome. So distal arteries correspond to the main segments of the cerebral arteries up to the end of their second segments, represented here on the C and D picture with the red lines. More recently, Laberry and al. Compared two populations with a conventional and distal angioplasty. So in the conventional arm, there is 160 patients treated with the hyperglide 410, and in the second arm, conventional plus distal angioplasty, they count 232 patients treated with Hyperform 47 or Scepter XC 412. So the differences between the two arms were significant in favor of distal angioplasty for less new angioplasty and less delayed cerebral infarction, but no difference was observed about death and outcome. So I will present you one case from our center, which is in press. We have a case series. It is about the Comanici from Rapid Medical. The Comanici is the first ever adjustable, fully visible remodeling device. It provides temporary assistance for coil embolization. For example, for wide neck aneurysm without limiting the blood flow. So it was thought in our center that it could be used for distal angioplasty. So this case is about a woman of 33 years old with a Fissure 4 subarachnoid hemorrhage with a brain hematoma explained by a carotid ophthalmic rupture aneurysm. This aneurysm was treated with coils. At this event, she presented a consciousness disorder due to a vasospasm of the A1 and A2 segments. As you can see on the first, the admission DSA, you can see the aneurysm, and you can see that the A2 and A1 segment are okay, and the parenchymography is also good. At this event, you can see that the parenchymography is lacking, and you can see that there is a severe vasospasm of the A1, A2 segments. With a zoom, you can see this clearly. So we deployed a Comaneci in place, and as you can see, the parenchymography came back to normal, and as you can see, the caliber, the diameter of the target vessels also was better. These are perfusion map of the mean transient time of CT perfusion. Before angioplasty and after angioplasty, you can see that the territories corresponding to the ACA segment, the anterocerebral artery segment, is very slow before angioplasty, and after angioplasty, it comes back to normal. About the follow-up MRI at day 26, it doesn't show any sign of delayed cerebral infarction in the ACA, in the left ACA segment. You can see the hematoma, which was known at admission, not corresponding to a DCN. So now I will talk to you about a national survey, a recent one, which is also in press, about neuro-intensive care, neuroanesthesia, and endovascular management of CVS. So it is a national survey from France, performed by a trainee-led research network of anesthesia and neurologists, the GENI and the Svargen. So why did we perform this survey? We performed it because there are no guidelines updates since 2012. And there's a lack of consensus regarding management of neuro-ICU, neuroanesthesia, and endovascular management. So all the cities of France were performing interventional procedures answered fully to the survey, corresponding to 29 cities. So what about cities? Cities indication for it was systematically performed for 44% of the cities, of the centers, but most of the centers answered that this computed tomography was performed only if there is any cerebral vasospasm suspicion. This suspicion was based on clinical data and abnormal ultrasound Doppler. About the protocol, most of the centers answered that they performed a brain CT with no contrast, with a CTA on the arterial time and a perfusion CT. 20% of the centers answered that they only performed a non-contrast CT with a CTA, without perfusion CT. The multi-phase CT protocol was not used in this survey. 3 centers reported that they got spectral CT, but didn't use it in the diagnostic of CVS. What about the CT semiology for refractory CVS diagnostic? The narrowing of the arterial branch was described with the subjective quantitative scale: 25% of narrowing, 50% of narrowing, 75% for 24% of the centers. But most of the centers didn't use any quantitative scale to assess the narrowing. About the perfusion map, most of the centers use the mean transient time, 56%, and only 42% use the Tmax and the CBF. What about the mean blood pressure target? In prevention and in post-intervention, the mean blood pressure target was for most of the centers between 100 and 120 millimeter of mercury. And it is important to notice that the mean blood pressure target was not clearly defined in the department for 26 centers. During the endovascular management, for most of the center, the mean blood pressure target was between 100 and 120 millimeter of mercury, and it was not clearly defined in their department for 19% of the centers. So about angioplasty and the conventional one, most of the centers answered that they performed only a chemical one, and the mechanical one was discussed on a case-by-case basis. 23% of the centers answered that they systematically perform a mechanical with chemical angioplasty, and 23% responded that they performed a mechanical alone and a chemical one only on a case-by-case basis. For the distal angioplasty, only 19% of the centers in France responded that they performed it on a case-by-case basis also. So about chemical angioplasty, most of the centers used a mixture of nimodipine and chorotrop, 59% of the centers. 18% of the centers used the nimodipine alone, which is, and 15% of the centers use chorotrop alone. To infuse the drugs, syringe pump was used for most of the centers. 15% of the centers used a manual infusion, and 4% of the center use pressure infuser. About mechanical angioplasty, a non-compliant balloon was used for 30% of the centers, but most of the centers used a compliant balloon. Only 22% of the centers used a stent to treat angioplasty, to perform a mechanical angioplasty. So about anesthesia, general anesthesia was performed for 54% of the centers, and if the patient was conscious, conscious sedation was performed for 12% of the centers, and local anesthesia for 15%. A case-by-case was discussed about the anesthetic modalities for 35% of the cases, of the centers, sorry. Anticoagulation during angioplasty was systematically performed for 42% of the answers, on a case-by-case basis for 23%, and never for 35%. So, in conclusion, to treat cerebral vasospasm and to avoid the delayed cerebral infarction, we can see that about the survey and about the lack of guidelines updates since 2012, we can see that there is a very heterogeneous practice in France about CAD protocol, CT semiology, about drug therapy, about blood pressure targets, and also about endovascular treatment, including the indication, the anesthetic modalities, and about the mechanical and chemical angioplasty. So we have for now to make do with the non-update recommendations and to perform, I think, conventional angioplasty, including the mechanical and chemical angioplasty to treat the vasospasm based on the perfusion CT. So thank you for your attention.